Next session on clinical phenotypes of MASLD. Can I please invite the chairpersons, Dr. Yogesh K. Chawla, Dr. Nora Terold, and Dr. Mohit Nanda to please chair this session.
The first session now, we move on to the next one, and this is on clinical phenotypes of MASLD. And to give the first talk, we have Professor Anil Dhawan, who is very well known in this audience. He's the professor of pediatric hepatology and the dean at King's College Hospital, and of course, a product of Chandigarh. And he's going to talk on pediatric MASLD current understanding. Anil.
Thank you, Yogesh. Ladies and gentlemen, and I would like to thank, like anybody, the governing organizing committee, Ajay, and last but not the least, Patrick, who decided to stay in the audience for this talk. He was going to go for a cup of tea. We'll go later. So, Patrick, thank you. So, over the next 15 minutes, I'm going to give you a perspective of pediatric MASLD. I don't know what we call it, but I will call it MASLD. I go back to late 90s when this term was brought in, NAFLD, and pediatricians joined the bandwagon as we do. And I felt, these kids can't be stigmatized, so we need to change the name. So first we started like that, change the name. So in 2016, we put up some data together from King's College Hospital, and we said, all that fat is not NASH. NASH was the word those days. And this was based on this about 500 plus children who had fatty liver on liver biopsy, most of them. And if you see, half of them had a definitive diagnosis. So they were not so-called NAFLD, that box that we said. And a small percentage, despite exhaustive workup, including targeted gene sequencing, we did not find a cause. So we call that a third type. So we said there could be put into, if you want to live with this definition, that time, please, pediatric NAFLD or so-called NAFLD those days could be seen differently. Children who had definitive monogenic disorder, children fit into that category of so-called NAFLD those days, and the ones who cause yet to be identified. To take it forward, we put it into JHAP, and that time the title of all that fat is not NASH. But now I like to make a point, and if you look on the right-hand side, all these conditions can cause fat in the liver. But they could have a fatty phenotype also. And I'm going to show you as we go forward how the epidemic of obesity has come up, and that is the elephant in the room. We are going towards organ-related things. I'm saying cardiologists are talking of hypertension, diabetologists talk of diabetes, but the elephant in the room is obesity. What I want to depict on the left-hand side is the pathogenesis of fat-related injury to the liver is based in the mitochondria. And there are so many mitochondrial conditions that children could have. Unless you exclude them, it will be not right to call them just again a MASH or SLD. This slide was shown part of it, but the modified version we want to bring it is that in 2018, we brought it the controversy in pediatrics, and we were part of the 2020 paper when we said it should converge and we should become a MAFLD, that was the type included, so that to include the various varieties of pediatric fatty liver disease that we see should be included, then everybody is under one umbrella, non-alcoholic, because non-alcoholic to us was double negative. In children, by and large, alcohol is not a problem unless they are auto brewery. So now in the pediatric field, it's seen as steatotic liver disease, and we have multi-societal endorsement now. But you see here also that it goes into 5 categories. So-called metabolic dysfunction associated liver disease that we're calling MASLD today, MASLD overlap, other single etiology that we said half of our patients were in that group, cryptogenic remains to be excluded, and alcohol-related liver disease, which is showing up in teenage children everywhere in the world. And this is the slide I want you to focus. So it has been said before, I personally believe that these specialists continue to be organ-specific morbidities. We are sometimes writing papers which draw attention that MASLD is killing children, but what is killing children is obesity and its complications. And MASLD is one part of that. But if you look at over the years, so King's College Hospital London has a database of Caucasian white children going back to 70s, and that database shows the gradual progression of overweight girls, boys over years. So from single X to triple X large, but boys are outshining 25% obese. That's quite a big population. The point to remember is these 25% of boys are not immune to monogenic disorders. Once a year or twice, we see a child with Wilson disease who has been managed as fatty liver, but he has something different. Now, if you look at the data that WHO has come with, BMI Z scores, we had a brief discussion yesterday. Does BMI really mean anything to the Indian children? I don't think it does mean anything. It meant for the Caucasian population, which has a different muscle mass, different bone mass. What is relevant to our population is maybe mid-abdominal circumference. That mattered to us. And that is maybe the more pathogenesis, that pathogenesis could be related to that visceral fat than just the BMI. The point I want to make here is if you look at this data where the incidence of obesity in part of India is 2.7% with Z score of 2.7 BMI Z score 2 may not be really relevant because Z score may not be the right marker to assess obesity in the Indian subcontinent. This is a data which is a meta-analysis of global prevalence and forecasting so-called NAFLD those days in children and adolescents. What it looks at is, if you, I think Dr. Janusi did point towards this data already, that the overall prevalence has increased from 4 to 9%. So that is a real data, I think, but that is on the back of increasing obesity from 5% to 35%. So that parallel is there. Obesity is much higher. The data is there is an increase in the prevalence of NAFLD those days is 4 to 9%. And these are the red zone. India is in the red zone already. Now, depend how do we measure this animal. So how do you define NAFLD those days? Are you doing ultrasound? Are you looking at the CAP on the fibroscan, MRI, liver biopsy, or a combination of each of the two? And you see the prevalence changes. Highest is CAP. Ultrasound is also the second most commonest, but I think by and large 8 to 10%, you'll all agree on that number. How do the children present? You must be wondering how do they come to us. They usually go with a broken finger to the accident emergency department. And these days, the special test, we run liver tests, and they come with abnormal liver enzyme, and they come to the liver clinic. So they have no symptoms. They are nice, chubby, fat, or within inverted commas children. But if you look at carefully, they avoid, in our practice, we see acanthosis nigricans. But you have to spend time, take their clothes off, and look at their axilla, look at the back of the neck, and don't embarrass the family, they don't wash them. They do wash them, but it's just the acanthosis nigricans. We insist on having abdominal circumference done in the clinic. And that's what we think is the most common or important information that we get. To give you a snapshot, I think what we are looking at is majority of our patients have insulin resistance. We were talking yesterday whether it's right or not. We insisted when we started looking at the subject in early 2000, we insisted on liver biopsy to understand more of the disease. Not anymore because many reasons, but those days, most of our patients had liver biopsy data and the blood biobank. In this slide, we show that in children at that age, not very high BMI of 25 median, they had abdominal pain as a presenting feature, 65% had insulin resistance, 40% hypertension, abnormal insulin resistance or insulin resistance is 69%, but 49% have splenomegaly. For us as a hepatologist who are thinking hepatology is portal hypertension, but I'm not so sure that's correct in this condition, whether it's inflammation-driven splenomegaly or it's a portal hypertension, because the fibrosis is not advanced when we did the biopsies. So that's something has to be kept in mind interpreting splenomegaly in a child with NAFLD or MASH or MASLD or SLD, what we call. Another way to look at incidence of fat in the liver, the donor organs. So pediatric donor organs data, if you look at, on the right hand side, what you look at is that majority of the children are having some degree of steatosis. So under 5% is the red microsteatosis, more than 5% is in the blue or green. So a substantial number of pediatric donor are having fat on the liver biopsy when they are acting as a donor. On the left hand side, what you see is as the BMI goes up, the degree of obesity, if they're obese by standards, then the macrosteatosis is very high, but in the overweight, it's not that much. Now, there is a slight difference in the liver biopsy findings. In early 2000, there was a data from our center from Italy that there was pediatric liver biopsies were slightly different than adults. And the difference was there was a pericentral or periportal. So fibrosis or injury was more periportal in children versus pericentral in adults. Why does that happen? We don't know, but there could be some indications here. There is a zonation, zone 1 to zone 3. If you look at glycogen synthesis from glucose is more predominant in zone 3. Similarly, triglyceride synthesis is predominant in zone 3. As the age goes, after 25 years of age, this zonation starts going blurred. So in pediatrics, it's very strict, but after 25 years, it goes down. There are other differences. Antenatal priming, we'll come to that. Dietary preferences. Children are the highest users of fructose. We give them fruits and more fruits. That's also sugar, but it's a fructose. There is a slight changes in the biliary patterns if you look at the histology. And as I said, type 1 versus type 2, and we have more fibrosis at diagnosis. Other factors, if you look at the epigenetic or factors that are coming from the mother. So if you have an overweight mother, insulin resistant, diabetes or gestational diabetes, you're priming the fetus already. When that primed fetus has a first hit, and the second hit will come later on if there's increased consumption of fructose or other high calorie milk. Genes are always central, and what I'm trying to say here is all this pathogenesis of the NAFLD is there is a genes responsible somewhere, and there will be a proper talk on genes, so I'm not going to spoil that. But what we found in our population is BNLP3 like other, and TMSS6F2 were predominant. This has been reported before, and what we think in children is there is a starting from male sex, ethnicity, family history, proper genotype, and then the major component is dietary, which is again increased calorie intake. In whatever shape and form they consume it, that's what matters. Now, how do we predict the future? And good thing about future is you can't predict it, but we try to. So we try to predict it from our past experience, and this data showed that it's a 20% may get better, 30% may get worse, vice versa for the steatosis. So, but the take-home message is as the disease progresses, it can go backward, forward. Whether it's a natural history or our interventions, we don't know. Very likely when we say your liver enzymes are not good, you may get worse. They may start drop their consumption of glucose or other saturated fats. So that's possible. But this is a persistent finding. More than one studies has reported that improvement and worsening can happen in a different cohort of patients. How do we can't predict who is going to get worse, who is not going to get better at this point in time. This is a prospective study, which is very interesting, which also proved the same point that if you have 24, 27 patients, if you look at 10 years later, 1/3 got better, 1/3 got steatosis, and their ELF test, again in 54%, increased by 0.5 units. So it's very unpredictable of the course of the illness. This is a long-term data study, which is again on a retrospective cohort, but it sends the message that the mortality in this group is higher. So there is a 4-fold mortality. Overall, 4% children have cirrhosis. In their children means they're going to young adults now. So they're not children anymore. But half the deaths were attributed as liver related. This is a standard of care follow-up. So difficulties here are, we don't know why didn't these children offer liver transplantation in today's world. The second is 50% of the children couldn't be followed up. So the difficulties in this population are there for every study. This is a very important data that shows us that this is not a benign disease. Liver transplant has been performed, at least reported on the retrospective cohort. We have not performed a single liver transplant, portal venous hypertension management as a banding or anything on any child with fatty liver disease in our clinic for the last 25 years. Management is very simple, and that's this for us. In our clinic, only 3 things we say: weight loss, weight loss, weight loss. We don't know how you do it, but that's the only thing it will change, and will treat the childhood MASLD. In UK and Mexico tried it, sugar tax, it has worked. So reduce the consumption of high sugar drinks, and that has reduced the incidence. So in the end, we need to take triple X to single X. If we achieve that, I think we will cure everything. So what I wanted to say in the end is that if you change the phenotype, that will change everything. But MASLD in children is not a liver pathology that's causing morbidity. But going forward, we are sending patients to your clinics, but there is a black hole in the middle. Before they become real adults, they are lost to follow up, and that's where lots of things could happen. So my message is, please look after them if they have a fibrosis in the childhood when they come to your clinic. Thank you.
Thank you, Dr. Dhawan. For the next talk, I'd like to invite Dr. Abhijit Chaudhary on the stage, please. Sir is going to talk about lean MASLD. How is it different from the normal?
A very good afternoon to everybody, and I'm really grateful to INASL, Dr. Duseja and the team for providing this opportunity to come back to Chandigarh, where we got everything that we are living with right now. What I'm going to do in the next 15 minutes is to share with you the way we try to understand the entity that has aroused a lot of papers, a lot of concerns, a lot of interest in circles, in scientific circles over the last 2 decades, more than 1 decade at least. Our group's association with MASLD in this group is quite long, and I'll discuss with you that. But before that, I would like to point forth, as you would see in the very outset I have presented, that I think we should get rid of the term called lean MASLD, because there is no entity that MASLD is not lean. So better let's call it MASLD in lean individuals, the way we hypothesized, me, Professor Sharnal and others hypothesized in J. Hape reports in 2019. Second is, we need to understand at the very outset that there is a common thought that possibly this group of people are not obese, but let me tell at the very outset that there cannot be any fatty liver disease, MASLD, whatever we call it, if we don't have an expanded adipose tissue, which in lean group we are not being able to evaluate or measure with the eyes, with the technology that we are using right now. So it's always expanded adipose tissue in disguise sitting somewhere. Second is, the group who is come to me at the present point of time as lean is in a dynamic phase of adiposity, and tomorrow the same person may be obese. So we need to understand MASLD in lean people in the dynamic frame as it should. So as I told you that way back in 2010 or so, we raised our eyebrows and looked at the entity, because we were also frightened that this paper may not be true, because we were getting fatty liver disease in a subset of people who were really not obese in terms, and who reported that. And around that time it was a fairly important eye opener, and some other groups were also working. But after that we had done some other work which I'm going to mention. So let's define how we take MASLD in the lean. So it's like, we exclude anthropometrically a person who has been found to have fatty liver disease, MASLD, which is histologically and imaging wise, and according to MASLD criteria, cardiometabolic risk factors, have got everything, but is not obese in terms of, or overweight in terms of BMI measured indices, that is 25 in Western literature and 23 in Asian criteria. So that's all MASLD. Why we are that interested? Why in India and South Asia it's that important? Is this famous Lancet paper that we always keep referring to. These two persons, one is a British and the other is Indian, have got the same BMI 22 and around, but the British have got a body fat which is 9.1%, and the Indian have got a 22% body fat, telling that we accumulate more fat, we are predisposed to have more fat at the same BMI, and BMI is an imperfect measure of risk associated with adiposity. And that's how the level for Indians and South Asians and Asians for that matter has been reduced, as the cutoff has been set at 23. We all know that. And that's how, and the question is why? Because a very interesting study had shown the left hand side is a South Asian's adipocyte and the right one is a Caucasian's adipocyte. As you can see, the South Asian's adipocyte is really plump, is hungry, and is angry too. Angry means it elaborates a lot of pro-inflammatory cytokines at a lesser trigger as compared to a Caucasian. And that's why, it's pretty well known that we South Asians are predisposed to all the metabolic ill health related conditions. Again, I emphasize, it's better that we try to understand MASLD in a metabolic ill health entity together. So we get cardiac disease at a lesser level of adiposity compared to anybody. We get kidney disease related, and we get diabetes, and we get fatty liver related to all these entities. Probably our adipocyte characters, behavior, and biology is as important as any other entity, and that's very important. Now, very important is how body fat is compartmentalized. So we have possibly, again, on the left hand panel you have got a person who is truly lean, and on the right hand panel you have got a person whose body fat compartments in intra-abdominal body fat compartments are different. So we have got visceral adipose area, we have got total adipocyte area, and deep subcutaneous adipose tissue which are there. While lean and obese differ that way, let me emphasize that in people who develop MASLD in the setting of BMI defined leanness, I emphasize BMI defined leanness, have got a normal BMI, possibly a normal waist circumference even, but have got a relatively higher visceral adipose tissue, relatively higher subcutaneous adipose tissue, and higher proportion of deep subcutaneous adipose tissue. This had been shown in some studies which were mostly done in people which was otherwise called normal weight metabolically obese people, MONW, and were primarily diabetes. Because again, I emphasize that we cannot get away from the thing that metabolic ill health is an umbrella entity. So we have got higher adipocyte mass per unit weight of BMI. Those people who have MASLD in lean have got higher fat reserve within the limits of normal BMI. So somewhere we are not exceeding the BMI threshold, yet we have got excess fat sitting elsewhere in the body, which gets inflamed, and as I will tell, which gets insulin resistance also. Otherwise you never can have the lipotoxicity and other features that characterizes fatty liver disease. So fatty liver disease per se in a person who is anthropometrically lean is the same disease that happened in the obese individual, which we are measuring. Reasons, but there is tremendous amount of data noise amongst the studies which you keep on seeing. natural history, in insulin resistance, in outcome, in prognosis, and all these features. And there are fairly big number of reasons for that. Issue is what you are measuring. You're measuring, how you're measuring and where you measure. You are measuring the population level, you are using liver biopsy as the starting point and all, and how you analyze and integrate available data. And I will not like to confuse you by presenting you the heaps of papers that have come in the outcomes of which are absolutely contradictory of MASLD in the lean people. But just to mention couple of them, initially there was a paper which showed that MASLD is, and that's the overall summary impression of most of the people in the arena, that MASLD in lean people, the initial two studies that I mentioned here showed are histologically driven studies, biopsied studies, and the next two studies that I mentioned here are really not biopsied studies, have used NITs as I use most often. So overall impression is that MASLD in lean people is generally have got a progression which is comparatively slower, although no conclusion has yet been drawn, have less or comparable insulin resistance as compared to people who are obese, have got an outcome which is better, and have got an overall mortality which is almost similar, if not the same, in people who are obese individuals. Treatment wise, let me emphasize, the only good study that I could get, and I believe this is one of those, is the one from Vincent Wong's group, which has shown that weight loss, and a lesser amount of weight loss is going to do wonders in people who are lean and have got MASLD in them. So again, weight loss remains the mainstay. None of these drugs have really been tried because we are yet to have a good clinical, armamentarium for therapy in MASLD. I think once the larger pot is full, people would focus on these clinical subphenotype of MASLD as we are discussing. Now, we have also done some, we try to understand what's the difference in by measuring, insulin resistance and other features in people and disease in people lean versus obese, both from a large community cohort and a hospital cohort. And this is just submitted, I'm not mentioning the details of that, but let me tell you that we found that insulin resistance measured by frequently simple IVGTT was similar in the two groups. The people who are lean had better beta cell function, again FSIVGTT measured, and higher proportion of android fat were present, but they had lower amount of steatosis, similar NAFL fibrosis score, activity score, less severe fibrosis, and similar prevalence. So we really didn't find much of a difference between the lean and the obese group amongst people who are and insulin resistance. Now, interestingly, I think this hypothesis is very interesting, and that's why I thought of mentioning this, that people, in terms of insulin resistance, insulin genesis, we all know that insulin sensitivity, as we go in the spectrum, in insulin resistance progressively goes down, and beta cell dysfunction also sets in later. And hypothesis as of now is that probably people who are non-diabetic and MASLD and lean have got a one step down to pursue the same spectrum of worsening insulin action, again telling that they are biologically the same group of people as the adult obese. Now, this study was interesting, and this is from Jacob George's group in Australia, and they found that people who are lean and had fatty liver disease have got a bile acid profile which is quite different, and microbiome profile which is quite different from people who are obese. And they found that, sorry for the quality of the slide, but they found that, these probably give them a metabolic advantage and metabolic adaptation. And so, probably obese group subset are metabolically maladapted to a greater degree compared to lean people. So, it's a question of how you adapt to the circumstances. Now, interestingly, we tried to look at the genomics of lean MASLD in the lean people in our population. This is a large population-based study which we just published in Journal of Genetics. This is from a Birbhum population. Large, we did a 1:3 sample, then did a final set, and high quality DNA we could get in more than almost to 1,200 people. And we found we could, this is a study which we published along with scientists at NIBMG. We found that PNPLA3 stands as tall as in other studies. But interestingly, we could also find some other interesting hits in lean group of people. This is a fatty liver, let me tell you. This is not really biopsied cohort of people. And ADH4 and other single nucleotide polymorphisms were expressed even in the liver in this subset of people, telling us that probably there might be areas of interest, genomic areas of interest in this group of people. Right now, Ankita, who is present here, is working with Ramanuja Dasgupta in Crookes Institute in Scotland we are doing some spatial transcriptomics in obviously biopsied people, single cell sequencing in lean and MASLD with lean people and MASLD early fibrosis versus late fibrosis. So we are comparing, as you know, single cell sequencing is very costly, $10,000 per slide. So F0, F1 versus F3, F4. And interestingly, I have got interesting data to share with you right now, very preliminary observation, but people who have got early F0, F1, this one have got F1 fibrosis and have got fatty liver disease, still have got significant endothelial activation, have got suppressive macrophage activation, CD8 as well as Tregs regulatory T cell activation, when we observe, telling us lot of immune turbulence is still happening when you don't have that much fibrosis. Again, the message for us, and we are digging deep this one, message for us is that it's not all that bland when we look at steatosis per se. This is how we look at the pathogenesis and evolution, and this is what we wrote in JHEP reports, that probably abdominal obesity, compartmentalization, and relative sarcopenia, which I didn't mention earlier because that's a very important entity possibly in Indians, sets the non-obese phenotype, the so-called lean phenotype. And there is accumulation of risk factors and modest increase in BMI and adiposity within normal range ultimately leads to a dysmetabolic state, and this along with the dysregulated gut-liver interaction with altered microbiota, altered intestinal permeability and all, along with the genetic predisposition, finally leads to appearance of steatosis and development of overt steatosis in non-obese people. So in summary, let me tell you that MASLD in lean is always the result of an expanded, dysmorphic, dysfunctional, inflamed, insulin-resistant adipose tissue. We need to keep this broad thing in mind. So it's adiposity in disguise, and dynamicity of adiposity needs to be kept in mind. The genomic factors probably sets the grounds, genetics, fat compartmentalization, these are all genomic factors, may be different in people who are MASLD and have got a lean habitus. Exposome, that is the triggers for inflammation, are variably poised. We have got diet, we have got ethnicity, geographically defined factors. Cultural factors are also very important. As you know, environmental stressors sends their signals to the gut microbiota also. So all these are possibly triggers that sets the transcriptome and metabolomic alterations, and the same pathogenic pathway sets in, which might have qualitative and quantitative difference, and we get the subphenotype with almost similar outcomes, similar insulin resistance, and management principles, which are also similar. Thank you all for your patient hearing.
Thank you, Abhijit. Kindly join us here. We don't have the third speaker. He has not been able to make it. So we can have extra time for question answers and discussion. So I'll open for discussion these two talks.
Dr. Anil Dhawan, Dr. Ashish here. This side, please. Sir, I wanted to know, you discussed insulin resistance. What will be your criteria in children? The anthropometric criteria and the blood chemistry criteria.
So we will.
In children, in adults too, we have some anthropometric criteria. Do you have any such criteria in children? The abdominal circumference, the waist to hip ratio, the height, or the plasma insulin levels, or the HOMA-IR? What sort of things you will use to define insulin resistance in children? Because we know puberty itself is a state of physiological insulin resistance.
There are no validated ones. So we use the adult criteria only. There are no validated in children yet, for particularly in the context of fatty liver disease.
Dr. Abhijit, what you believe would be the contribution? We have three parameters: the visceral fat, the sarcopenia, and the fructose intake. what should be the parameters would be most contributing to this lean mash? Whether excess fructose intake, whether poor muscle mass, or the excess visceral fat? What should be the most important among these three?
I mean, these are very important research questions which have really not been answered in the right way. I think we cannot really, silos this into. So, relative sarcopenia as well as adiposity, excess visceral fat, both would be important. How much in which individual is what needs to be worked up. Obviously, fructose consumption would be important, but that's in the broader umbrella of fatty liver disease, not specially in people who are lean, but sarcopenia is possibly very important. But why I say possibly is we raise questions and we are yet to answer all these questions. There is no hard data which had shown, conclusively that this is a contribution of sarcopenia and this is a contribution of visceral fat. Both are important.
Because the treatment will depend whether you want the patient to lose weight or gain muscle mass.
You lose weight, you gain muscle mass, both.
Weight or fat loss.
Yeah, you lose fat mass. You don't lose muscle mass.
Secondly, the fructose one I was asking, because fructose, as we know, is metabolized mainly in the liver. It's not metabolized. Is it purely the excess fructose intake in India which is responsible for more lean NASH as compared to the West, where more of glucose intake is there? So is there any data of the same?
I don't think there is hard data to suggest or refute either.
Thank you, sir.
Just a correction here. Dr. Musimo's talk would be there in the late evening. So the organizers want us to finish this in 5 minutes time. So quick questions, quick replies.
Yeah, my question is to Dr. Chaudhary. This theory of fat being hidden somewhere is very difficult to accept. Is it not possible that lean NASH may be a variant of something like lipodystrophy? You do have no fat in the subcutaneous tissue, so that is the reason by default it is getting deposited into the liver and is producing all the problems because of the fatty liver disease. So how is it that in today's technology you have expanded fat which is disguising? Not
lipodystrophy per se is a different entity altogether. I mean, the lipodystrophy.
It may be just a variant of lipodystrophy, lean NASH. Why not?
It's not purely lipodystrophy because there are studies which have shown by well-defined, unfortunately, we don't have such studies in India available or the Southeast Asian countries where, right now we can really do a good MR-driven with compartmental studies, and that has shown that really fat is present in ectopic site. So it's ectopic fat. It's not lipodystrophy. Lipodystrophy is a different absolute pathological entity.
And if you theorize that the subcutaneous fat in lean NASH is dysmorphic, dysfunctional and inflamed, why not do a biopsy, subcutaneous biopsy of a lean NASH and a normal conventional NASH and see the difference?
One should. These are good, that's why research questions.
Sir, so, I was just about to ask this question which Dr. Anil asked. Don't you think that in this case, we should have something in a form of PDFF which is coming up in a big way and we really need to validate that?
See, PDFF is good to label somebody as having excess fat. But PDFF does not give you more than telling a macro picture of excess fat. It does not localize fat anywhere. It does not give you a compartmentalization of fat, and it's a very sort of big way of looking at excess fat.
Probably it's new. That's the reason behind.
Pardon?
Because this entity is not being worked up too much.
It has not been worked with the vigor and the rigor and the meticulousness that it's needed. That's possibly one of the reasons. We need more.
Dr. Neela, a quick question. Overweight children and obese children, sir, you said that need not be the same as regards to the fatty liver is concerned. And I didn't get that. If a person is obese, will that not be having some amount of fat coming up in it?
Oh yes, what I was trying to the data, if you are looking at obese child versus overweight by BMI, so that's BMI based data, their severity of fibrosis or fat in the liver is disproportionate. So that goes without saying. You will say, why is that question? But that was a data on the donor livers what was the difference between the BMI and the fat content? Yeah.
So my question is for Dr. Anil Dhawan. As you rightly said that the elephant in the room is the obesity. Now, a lot of children will have elevated enzymes and parents are quite apprehensive. So till what level do you do that workup for them? Because some might have AIH or Wilson's, etc., and so on also. But so many children will have enzymes which are going on, elevated enzymes for a long time.
So we categorize by age. So under 5 years of age, it's a red flag. We will not call a so-called NAFL SLD. We will look for a single base or monogenic disorders or conditions that are inherited. Then the teenage population where the so-called NAFL, MSLD, MASLD is very common now, we exclude treatable conditions. And first thing is Wilson disease, autoimmune hepatitis. Once you have done that, then depends how far you want to go. And if there is a discrepancy like a lean person, we will exclude a lipodystrophy in a young child if we have that picture. And we have children with lipodystrophy who have fatty liver and steatosis also. So the treatable cause should be excluded. Once you have done that, then after that, I think weight loss, and weight loss.
Thank you. I think we close this session. Question later on. Okay. Yeah, so the organizers want us to close. Thank you, both the speakers and my chair.
Thank you, chairpersons, and thank you, speakers. Can I request you to be in the center of the stage for a group photograph, please?